Good evening, everyone. It's been a long weekend for me, so I've been teaching ECGs for the entire weekend, and so this is part of our Northampton ECG interpretation course. And I thought it'd be useful to have some bits on supraventricular arrhythmias because obviously it is a major potential impact in terms of device therapy. And the potential for inappropriate device therapy. So I've got some stuff here that I'd like to go through, which includes specifically supraventricular arrhythmias, and then we've got some clips on how we get things like AV nodal re-entrant tachycardia, AV re-entrant tachycardia, and when my computer does something, there we go, thank you very much. Come on. Oh, it's been really slow. There we go. So we can look at the classification of SVTs, including sinus tachy. We'll look at sinus node re-entrant tachycardia, atrial tachys, AF, atrial flutter, AV nodal re-entrant tachycardia, and then the different forms of AV atrioventricular re-entrant tachycardia, including orthodromic, antidromic, and also pre-excited atrial fibrillation. And these obviously have a major potential impact in terms of device therapy. So we can also classify supraventricular tachycardias in terms of their RP relationship. So we have what's a long RP and also a short RP tachycardia. So that's dependent on looking at your QRS and then just measuring back to your P wave. Is it short or is it long? And from there, we can classify, if my computer moves, which it does, very slowly, into the short RP tachycardias, which include a typical AV-NRT, so typical AV nodal re-entrant tachycardia, orthodromic AVRT, and also an atrial tachycardia. And those that have got a long RP tachycardia, which include an atypical AV-NRT with a fast slow pathway, sinus tachycardia, atrial tachycardia, sinoatrial node re-entrant tachycardia, and some very rare forms of AVRT as well. So what we'll do is we'll just go through those and just look at those as examples, and then we'll look at how they're actually generated. So let's start off with sinoatrial node re-entrant tachycardia. So this is a re-entrant tachycardia, so therefore it starts with an abrupt onset. It may have a gradual offset, and generally, because it is around the SA node, we end up with a very similar P-wave morphology to those in sinus rhythm. They may have some minor differences when we look in leads 2, 3 and AVF, but generally it ends up with a very similar morphology to that we see in a sinus rhythm. The rates, typically the classical rate is actually 127 beats per minute. Why it's 127 beats per minute, I don't know. But the range is between 100 and 140 beats per minute. And if we look at this example we've got here, we can see we have our PQRS coming through, and then we have a slightly different P-wave morphology when we compare it to those that were in the SA node re-entrant tachycardia, but it is very similar, but just very subtly different. So how does this all come about? So fingers crossed this works. Is that working? Yes, it is. Good. Is that working? Can you see the movie clip?
Yep.
Yep, good. So we end up with a re-entrant tachycardia around the SA node. It then ends up going down the AV node using the His-Purkinje system. So we end up with a narrow complex, which looks identical to sinus rhythm. The only difference is the fact that sometimes the P-wave morphology can be slightly different. Bachmann's bundle is still working, going across to the left atrium, but we do end up, as I say, with a P-wave that is just very slightly different, subtly different, about the same as a glass of Sauvignon Blanc versus the original. But it's very, very similar. Generally, this shouldn't have an impact on device therapy. You're generally going to be at a rate that's below those that are impacted, but it may just impact in terms of looking at rates. And when's the commonest time that this occurs? Often it occurs after people have had an EP study, they've had an ablation. Sinoatrial node re-entrant tachycardia is very common after we had intervention within the atria, rather than it being a native problem with the heart. Other options we have, so, sorry, go ahead.
Quick question. Can you get this with any, for instance, doing a threshold test in the atrium?
Absolutely, that still classes as intervention within the atria. So yeah, so you can trigger this by pacing, usually in the immediate implant period rather than chronically. So if you've got someone who's got an RA lead in that's been in for like 5 years, it's very unlikely to get anything initiated by this. Whereas if you're in, coming up to the first checkup, 6 weeks down the line, then yeah, absolutely, that's a sort of time window we're looking at for getting that. And it's completely benign, it's just a minor issue. It doesn't cause any major problems. Is that okay?
Excellent. Yeah, thank you. That's brilliant. Yeah.
Okay. Sorry, my wine's not finished. Okay, so atrial tachycardias. So this is a narrow complex tachycardia, generally rates over, well, it has to by definition have rates over 100 beats per minute. And the P wave morphology very much is determined by where in the atria we're going to get things. Diagnosis by definition is greater than 3 consecutive beats. And the QRS morphology should be normal unless we're expecting there's an underlying bundle branch morphology. And we expect to have an isoelectric baseline compared to that we see with an atrial flutter. Whereas we never, with a true atrial flutter, be that left atrial or a right atrial, we do expect that there will no longer be an isoelectric line, whereas with atrial tachycardia, we expect to be an isoelectric line with a atrial tachy P wave morphology that occurs intermittently. They tend to be quite quick, so we often get 2-to-1, 3-to-1 heart block, and as I say, they can occur in both the left and the right atrium. And we can actually make a decision on whether we think it's like to be left or right atrial in origin by looking at the P wave. It's negative or neutral in AVL, then we expect that that's going to be in the left atrium. If it's going to be positive in V1, again, we expect it to be in the left atrium. And fingers crossed this will work. It's working. So here we have an example of a left atrial tachycardia. We've actually got an inverted P wave across here. So this is occurring this way. It's actually using Bachmann's bundle reversely to get into the right atrium before then going down the SA node. But generally, that doesn't cause any major conduction issues. We still end up with a P wave morphology in advance of our QRS. Every single one of these images that you see on here have been generated via PowerPoint by me spending hours doing them. But anyway, there we go. Right atrial an example. So in this case, we often end up with a P wave that looks very, very similar to the native P wave that occurs in sinus rhythm, because we're aiming to have something that's very close to the SA node. It ends up in Bachmann's bundle in a similar fashion, but the only difference we have often is a P wave that's just subtly different to the P wave morphology that we have with the sinus beat. And these are just some ECG examples. So here we have a right atrial tachycardia. We have a rate of around 160, 170 beats per minute. We have a P wave that's just visible before the QRS, narrow complex, not very good ECG, but it's a real one. And here we have a left atrial with a positive P wave that's visible in, again, apologies for the quality, but they are real ones. And so this is a positive P wave that we can see here in V1 with a rate of around 140 beats per minute. In this case, again, a narrow complex. Atrial tachycardia, they can be precipitated often by having had an AF ablation. When you've got a lot of burning within the atria, that in its own right can lead to individual tachycardias that can be a bit of a nuisance. They can be a problem in their own right, and they tend to occur generally in the elder population rather than the younger. So if we now look at AV nodal re-entrant tachycardia, which is obviously the most common form of SVT that we've seen, this involves a re-entrant circuit in or around the AV node, and often you can end up with a retrograde P wave that's often visible or hidden just in the tail of the QRS. And this can lead to the formation of what's called a pseudo R wave in V1 or a pseudo S wave in the inferior leads. So if you look at this person here, who happens to have a sinus beat over across here, and if we look at in lead 2 and then in V1 across here, When they go into an SVT, we end up with this little beat across here, which is actually a retrograde P wave on the tail of the QRS, simulating a pseudo R wave in V1, but it's not really an R wave. And in lead 2, we can end up with this S wave that's occurring, which was not present beforehand. So there are some subtle changes on the 12-lead ECG during a tachycardia that can give you some guidance that this is likely to be an AV-nRT. Obviously, you can never be 100% sure, but it's a useful little guide, and it's a good game to play when you're actually looking at people with the 12-lead ECG pre and post SVT. When we have an SVT in this case, so here we have a narrow complex tachycardia, rate about 150 beats per minute. There's no obvious P wave visible, but you just get the suggestion, is there something there just after the R wave? Is there a little S wave in there? But you're not 100% sure. And obviously in this case, we've got this recirculating pathway going around the AV node, going simultaneously down the His-Purkinje system and also up to the SA node to get across to Bachman's bundle. And that can then lead to, obviously, a P wave occurring at least late and sometimes into the tail of the QRS. So here's just another example, just showing us here we have this simulated R wave that's occurring at the tail of the QRS, and this can be a marker going, yep, this could be an incomplete right bundle, but actually you're looking at it and going, well, could that actually be a simulated R wave relating to the P wave from retrograde conduction during an AV-nRT?
JT. Yeah. So back to the previous ECG. So yeah. the ST like slight upslope of the ST depression, is that like rate related, like ST depression? That
yeah, I mean we're looking. Sorry, the graph paper doesn't present very well, but this has probably got a rate around 170 beats per minute or so.
Okay.
So seeing this upsloping minor lateral ST depression is very common. So if we, when we exercise pilots and they're youngsters, we see this sort of stuff all the time. And if you actually measure that at the J plus 60 to 80 milliseconds, then that will be normal. So there's. Although it looks grossly abnormal, actually, when you measure it formally from 60 to 80 milliseconds, it's actually normal.
Normal, yeah. So what I mean is it's non-ischemic. It's not.
No, not at all.
It's really
true. I mean, it's very similar to an exercise test. So if you look at that, it can, when you do an exercise test, you can get ST depression in this immediate post-QRS phase, but that is not a marker. You do have to just ignore that and go to 60 to 80 milliseconds before you make an assessment of whether there's any ST depression.
Yeah, spot on. Brilliant.
Good. So that's AV-nRT. All right, we'll be able to get out this window. Oh, what's happened? Oh, the world's ended. Let me just reopen that. So, all right, back there in a second. So is that back there now, is it?
Yeah, that's fine. Yeah.
Let me just go on. Good. So let's go on to AV re-entrant tachycardia, which generally people consider to be related to Wolff-Parkinson-White syndrome. So Wolff-Parkinson-White syndrome is the presence of the accessory pathway plus palpitations. So you can get an ECG on its own, which shows pre-excitation, but the patient has no palpitations. They don't formally have the diagnosis of Wolff-Parkinson-White syndrome because it is a syndrome, including symptoms as well as the ECG abnormalities. There is a small risk of sudden cardiac death related to pre-excited atrial fibrillation, and this tends to occur under the age of 40, such that if you have someone who's now 40 plus, then really there's no benefit in looking at an EP study unless you're looking at symptoms, because you're not going to alter mortality, whereas under the age of 40, then an EP study has the potential to reduce the mortality of that patient. Most pathways that are present can conduct both antegradely and retrogradely. It is quite uncommon to get an antegrade only or a retrograde only pathway. It does occur, but it is incredibly rare. So when we're looking at someone who's got arresting evidence of an AV re-entrant tachycardia, Well, we're looking generally that people who've got a PR interval less than 120 milliseconds, going to the nearest deflection after the P wave. Generally, they'll have a QRS because of that. They'll end up with a QRS duration generally greater than 110 milliseconds with an overt delta wave, which we can see in this example across here. We have a short PR interval. In this case, it's around 80 milliseconds. We've got a delta wave. And then after the rest of the conduction of the heart is being conducted by the normal AV node, we end up with a QRS that looks relatively normal. So here we have an example of overt pre-excitation at rest. This is easily visible when we look at the lateral leads. We have a very nice delta wave, and we have a P wave that actually morphs straight into that QRS. Across here, there is, the beginning of the PR is probably 80 milliseconds at max before it goes straight into this. And what are we looking at? So we're looking at most of the electrical supply at the beginning of the beat goes down the AV node, which is down the accessory pathway, which is non-decremental. So it just allows the electricity to go straight down the pathway without having to go through the AV node, which obviously is an organism for pausing electrical supply. So most of the electricity goes down the AV node, depending on where it is, down the accessory pathway, pause down the AV node, but because the rest of the electrical supply is using the His-Purkinje system, that tends to be quicker than those that have been using the accessory pathway. So that takes over, which is why we end up with the QRS that looks roughly like that which we had started with before without the accessory pathway. So when you go into an SVT with an accessory pathway, 90% will go into what's called an orthodromic. So that involves going down the orthodox route, which means going down the AV node, but then back up the accessory pathway. And because you're now going up the accessory pathway, no longer using the accessory pathway in the antegrade fashion, you have no delta wave. So as soon as you go into the SVT, the delta wave has completely disappeared. We have a narrow complex, which has got a rate of, in this case, around 170 beats per minute. There is no P wave visible because that'd be into the QRS. And that occurs because we're now doing a route going up the accessory pathway, back into the right atrium, down the AV node, and then coming across the right, in this case, we're going across to the left ventricle to get across and then back again. So that's why the delta wave completely disappears. But not everyone does that. So some people have an antidromic AVRT. So in this case, we end up going down the accessory pathway and everything you can see is related to a delta wave. So you end up with an ECG looking like this, which looks absolutely awful. You look at this and often in A&E, the patient will come in and they'll go, oh my God, and then they will then get electrocuted, which actually isn't a bad thing. They could have adenosine. It's not an unreasonable thing to do because they're not in atrial fibrillation. If they're in atrial fibrillation, you give adenosine and someone has got pre-excited AF, as we'll look on the next few slides, that is a disaster. But for somebody who's in a antidromic AVRT, then if you give adenosine, generally you will just terminate the SVT. But it looks bloody awful, and certainly A&E will not give medical therapy for this. So we're now going all the way through this. We're using the His-Purkinje system to get back into the septum, to get back up to the AV node, to then get back across to restart things. So everything is coming down the accessory pathway, and that leads to everything you see on a 12-lead ECG is in fact a delta wave. I'd like to point out my chicken is nearly done in the oven, so I have 5 minutes. In 5 minutes, I will just have to pop out and go and take literally the chicken out of the oven. So this is an ECG that is the most concerning ECG for someone attending A&E in my opinion. So here we have someone who has a broad complex tachycardia by definition. The QRSs are broad. We have a tachycardia rate of up to 190, 200 beats per minute. But the features on here that concern me in terms of an A&E attendance are: one, it's irregular, and two, we have varying QRS durations, which suggest, they state that this is pre-excited atrial fibrillation. And if we look at the shortest R to R interval over here, it gives a rate of less or at least 300 beats per minute. Now, if someone along this lines is then giving some AV nodal blocking drugs so that no longer is the electrical supply allowed to go down the AV node because it's been blocked, it therefore goes down the accessory pathway, and this 300 beats per minute will become persistent, and that leads to ventricular fibrillation and, if left, death. So pre-excited atrial fibrillation such as this do not give any drugs whatsoever. They need to get electrocuted as soon as possible. What's it look like? And this doesn't present very well, but we'll try my hardest on this, where we end up with stuff going around the left to the right atrium, and then various bits will come down the accessory pathway. Some will come down the AV node, and the QRS duration is dependent on how much percentage-wise is going down the AV node and how much is going down the accessory pathway. If everything goes down the accessory pathway, we end up with a very broad. If most things go down the AV node, then we end up with a very narrow QRS. But the bottom line is pre-excited atrial fibrillation like that, use some electricity. Atrial flutter. So here we have a typical counterclockwise atrial flutter. So we go around the inert parts of the atria. So the fossa is inert, the coronary sinus, obviously because it's a tube, is inert, the IVC is inert, and the tricuspid annulus is inert. So we end up with the electrical supply going through this gap between the cavo-tricuspid isthmus, and this is the area where we can do an ablation for atrial flutter. The majority of typical atrial flutters will be counterclockwise, but not all. We can end up with a typical typical clockwise atrial flutter as well, but that's about less than 10% of cases. And here we have an example of someone who's probably in atrial flutter with a complete heart block. Looking at it, they've got a relatively narrow QRS, but actually they're completely regular, and there's no association when we're looking at the flutter waves and the onset of the QRS. But we can see here a typical slow downslope, rapid upslope of a typical counterclockwise atrial flutter. Atrial fibrillation, sometimes it can be difficult to actually manifest any obvious features that we do for atrial fibrillation, but the big thing always as ever is to look at the rhythm. So if we have a completely irregular rhythm, where it's completely irregular, no regularity at all, so regular throughout, even if you can see what you think is organized atrial arrhythmia underlying it, if it is completely irregular, then it is atrial fibrillation, full stop. And this is just a slower example to demonstrate how difficult it can be to look for atrial fibrillation in terms of the isoelectric line and whether there's any evidence of atrial fibrillation. Here we have an isoelectric line which is almost completely flat, but when you look at the rhythm strip, it is completely irregular. There's nothing on here that says atrial fibrillation. This is almost flat, but the irregularity is the bit that tells you this is atrial fibrillation rather than something else. Right, I am going to have to stop at this point. If anyone wants to go to a bathroom break, I've just got to go and take my chicken out of the oven, so to speak. I will be back very shortly. Oh. My chicken, there we go, it stopped, there we go.
Yeah.
Oh.
So it's interesting, if you looked at that last clip, I don't know about you, Julius, but just looking at it from, you know, a quick glance, I would say, oh, you know, PACs, right? Because it almost looks like there's some degree of regularity in the rhythm strip. But then when you really actually look into it, if you pull out the calipers, he's right, there seems to be some irregularity to it.
Yeah, that's right. Absolutely. Yeah. Yeah, so AFib, yeah, with an isolated ventricular ectopic, and when you've got that right bundle branch block in V1, so that's typical of, like, I think AFib. I think it's to do with the conduction the right bundle branch and the left bundle branch. I'm trying to think about the name for it. What's it called, JT?
What's that? Sorry, I've just got back. My chicken looks really good, but thank you. Yeah.
When you get a slow, fast, with AF, and you get like a right bundle branch, just after that, because the left bundle has not recovered yet, so it conducts with the right bundle.
Like aberrant conduction, or
no, not aberrant.
There's a name for it.
There's a name for it. It just escaped me just now.
Yeah, I know.
Yeah, it'll come to me in a sec. So this is a really good one for that. When you get a slow conduction, and the other pathway, say the right bundle has not recovered enough yet, so the conduction prefers to go through the left bundle, so you get a right bundle branch. It's just gone out of my head. It will come to me. This is a
while since that, so Right, shall I continue?
Yeah, yes, please. Yeah.
Actually, having said that, I've done most of this actually already. But so this one was just a marker just to demonstrate the difference between the potential for looking at the
Ashman beats.
Actually,
yeah.
So on here you can sit here looking, going, is that atrial flutter, is atrial fibrillation, and you're faffing around trying to make a decision. And the bottom line is ignore what you can see as potential fibrillation / flutter waves and go back to, is it irregular? If it's irregular, it is atrial fibrillation, full stop, end of, don't do anything else. So that was just a slide that gives me the option, if I need to go through to any of the other ones that we've seen. And the rest of the, I'm just going back through, are just examples actually. Excuse me. It's the same one. So these are just some real life 12-lead ECGs. This is part of my ECG course, so hence asking them what they are. I'm not going to do at this point, but here we can see actually we have this pseudo R wave just visible here in the tail of the QRS for the T wave, and in fact that was not present at rest. And this really does tell you that this is an AVNRT that is occurring, and this little pseudo R wave here is a nice little marker. If we look at an example over here, this is actually related to an AVRT. We've got nothing at all. There is nothing in there in V1 showing as a suspicion of a pseudo R wave. This is just a typical counterclockwise atrial flutter, and over here in V1 we can see the organized atrial arrhythmia over here, but over when we look in lead 2 we can see we never ever have a true isoelectric stable period. Everything is continuously moving, and it's just that this second beat of the atrial flutter goes through the QRS. That's the only period where you think, oh my God, there could be something isoelectric. There's nothing isoelectric. It is continuously moving with a slow downstroke and a slightly quicker upstroke of a typical counterclockwise atrial flutter. In this case, at a rate of 150 beats per minute with a 2-to-1 block. This is just another. This one ends up being a AV nodal re-entrant tachycardia. There is nothing suggesting a retrograde P wave that we can see across here. We have a narrow complex and no other abnormality noted. Okay, so yeah, so really, that's, as I say, I've stolen that presentation from what I've been doing this weekend. So they've got a narrow complex because we're using the HIS-Purkinje, which is part of the course. And one of the things I think is quite important, if you do see something that is irregular, but it does look like flutter, then flutter doesn't give you irregular. It is atrial fibrillation. The atrial ectopics, you can ignore that because that's part of a separate little slide there. happy to take any questions. And my chicken looks really, really puffed.
So it was interesting you were talking about don't trust the EKG when looking at flutter. I don't know if you all have seen this before, but I feel like even looking at EGMs, for example, right? Like EGMs, you can really tell what's going on in the heart generally compared to an EKG because you have a lead inside each chamber. But sometimes when you're in the appendage, I feel like I've seen it where it looks very organized, but it still is a fib. So you end up with some degree of organization.
You do see that, and you know, ultimately, if you have something that does not map into something that would do into an atrial flutter, be it a 3-to-1, 4-to-1 block, whatever, it can't be anything else apart from atrial fibrillation. You know, there's no other mediated mechanism for being that. So you're quite right. You look at stuff that looks really organized, and then you look at the 12-lead ECG, and you go, "There's no way that can map out to be an atrial flutter." Then that second part is true. It isn't atrial flutter, it's atrial fibrillation. So AF can have some really organized periods where you look at it and go, that looks like an atrial flutter. That is atrial flutter, full stop. But when you map it out, it is completely irregular.
Yeah. I've got a quick question. So to do the slurring of the pre-excitation. Yeah. So where the accessory pathway is, at the junction, atrium and ventricle, like at the junction, does the size of the slurring or the delta wave depend on where it is, where the accessory pathway is? So if it's at the far end of the lateral LV wall, yeah, compared to if it's in the septum, yeah, like is this?
Absolutely. So it's all time related. So if you've got something that is very close to the AV node, then it's come to the AV node at the same time as it goes to the accessory pathway, then you will get overt massive amount of pre-excitation because the AV node is going to be decremental, it's going to stop, nothing comes through, everything is going to go straight down the accessory pathway. If you've got a free wall lateral LV accessory pathway, it's going to go down through Bachman's, it's got all the way around the atria before it even gets to the accessory pathway. So the amount of pre-excitation that you get may be very minimal because a lot of the electrical supply has gone down the AV node before it's even reached the accessory pathway, even allowing for the fact that the accessory pathway is non-decremental. So yeah, you're quite right. Does that answer your question?
Yeah, brilliant. Yeah, fantastic. Thank you.
Sorry, yeah, passed away there. I said, there we go.
That's a really interesting question. So you said when you talked about non-decremental properties as well, yeah, do you ever see decremental properties in accessory pathways, or is that just a AV nodal thing?
Doesn't happen. Doesn't happen. Full stop. It's purely an AV nodal function, and it's designed to have that function. That's how it works. So you don't get it with an accessory pathway. It is non-decremental.
What about AV nodal decremental properties in retrograde?
Ooh, is that decremental? Yes, it is decremental. So yes, yeah. So when you've got someone who's got VT and you get retrograde P waves, you can get Wenke-Back phenomena, you can get 2-to-1 heart, but you've got everything you can get. Exactly the same you could do antigradely.
Yeah, spot on.
Any other questions?
Well, so what about, I mean, I know a lot of EP consultants don't believe in this and its existence. I think I might have asked you this before about Long-Gannon-Levine syndrome, like accessory pathway in the AV node itself, like, which is quite particular.
Yeah, it is. I mean, that's actually related to an association with deafness. You know, it's not related. You know, it's a syndrome. And so, yes, we do get accessory pathways that bypass the AV node. Generally, they tend to be not able to conduct in a circuit, so they don't cause SVT. What they do cause is a short PR interval and potentially an ECG that represents pre-excitation. So I've had an interesting pilot recently who's gone for his EP. So he came to his medical, had his resting ECG, he has overt pre-excitation. So I got him referred. He went over to a colleague in Packworth. He had his EP study, They did his ablation. They got away with, he had this overt inducible SVT. They ablated his accessory pathway, which is a left lateral free wall. We got rid of that, and actually at rest, his ECG still showed a short PR interval.
All right.
So they went, okay, but they were completely non-inducible. They couldn't induce an SVT, whereas previously they were able to do so. So what they were able to measure, and I'm no longer an electrophysiologist, so I don't know the ins and outs, but they were able to measure and go, actually, this is not related to an accessory pathway anymore. This is related to an this is related to an extra pathway going alongside the AV node, and that is what causes the short PR interval. It's unable to sustain an SVT, and it's completely clinically irrelevant.
Yeah. Yeah, brilliant.
Now it's unable to sustain. Is it because of it doesn't have the retrograde? Like, why is it unable to sustain? I guess if you don't mind alluding on that a little more. Yeah.
I don't know whether it's related to the antigrade retrograde properties or related to its abilities to sustain in terms of rate. I don't know, to be honest. Either way, it doesn't do it, and the electrophysiologist sent me the letter said it can't sustain an SVT. Full stop. And I was like, well, that's what I needed to know from an aviation point of view. Any other questions? Am I still here?
Yes, you are still
okay,
here.
well, a few blimey. Oh, no, Lord. It was very silent there for a while. My Lord, on my own.
Yes,
The zombies are going to come and get me. Oh, no.
Yeah, great talk, Dr. Timperley. The type A and type B, is there any obvious way to distinguish it on the ECG? Because you have a lot of fellows
but it's, to be absolutely frank, it's completely irrelevant, because as soon as you get into the EP study, you then work out exactly where it is. So it doesn't add anything clinically. It's one of those things you do to knock around in the lab before they go to go and have their procedure. Say, oh, what do you think it is? It's going to be left-sided, right-sided, and it's generally it's reasonably accurate, but it's irrelevant. You still need, if you've got pre-excitation and they're under the age of 40, from a prognostic point of view, they should have an EP study to work out if they are at any excess risk or not.
Yes.
Over 40, you can make a case going, oh, this is interesting. Have you got any symptoms? No. In which case, you can make a case over the age of 40 going, we're not going to do an EP study because we're not altering mortality anymore. We're only doing it from symptoms. If they've got no symptoms, then why are we doing the EP study?
Yep, good. Then the next question is on issue of coronary sinus reading. Dr. Timperley, coronary sinus reading or any reading coming from coronary sinus reading. A focal point from the So a focal point, if there is a focal point from the coronary sinus, with the P wave, is there any difference in the P wave compared to a focal point coming from any point of the right atrium or the left atrium?
I mean, it depends where in the coronary sinus it is. So if it's coming from the coronary sinus os, then generally it looks like a right atrial. But if it's coming further around, you can end up with a left atrial looking one. Having said that, you're not going to get a patient inside there. So it's a moot point really, because it doesn't add to what we're going to be doing. What's the most likely one to occur? I don't know is the honest answer. It's probably more likely to be in the CS os rather than deep into the CS. So most of them will look like a right atrial.
Okay. Now, my next question is on the issue of multifocal atrial tachycardia.
Yes.
What do you have to say on it, sir?
Yes, it's a nuisance. It's a bugger. I think there's two major age groups that it occurs in. One is younger people and one is older people. The older ones are easy. Just give them amiodarone.
Yes.
Give them give them more amiodarone. The other group that it tends to occur with, which can be problematic, is either pregnant females or young females. And then you've got a difficult problem because, multifocal atrial tachycardia, ablation is a useless procedure for it. So you're left with medical therapy.
Yes.
So, sorry, my lights have just gone off. Just turn that back on. You're left in the situation going, well, what can we do medical therapy wise to do things? And ideally, amiodarone works really well, but you don't want to be giving that to a youngster. So it's difficult.
Okay. Thank you, sir.
No easy answer to it. You know, but obviously try a beta blocker first. And a younger patient, probably you can try flecainide as well to try, but it may not be very, very helpful, but it's worth a go before considering amiodarone.
Great, just quick. So I know you've spoken about, I just want you to clarify for the maybe it's people who are learning about ECG, that on an ECG tracing, when you see the slur in the delta wave, that's called a manifest pre-excitation. Manifest.
Overt is the term.
Overt pre-excitation. And then the one that you don't see, which is the dodgy one, which JT mentioned, the concealed accessory pathway, pathway, is when they're basically nothing. They've got normal ECG tracing, and then they're playing football, and God forbid, or somebody going some kind of atrial tachy or AF, some SVT, and it conducts straight down the accessory pathway as a preference for that, and then they go into that really fast rhythm. That's the one that you can easily die with.
Absolutely. So the issue there is so when you end up with an accessory pathway that's a long way away from the AV node, at rest, you may see no evidence of pre-excitation on 12-lead ECG because all of the conduction is going down the AV node. And it's a long, long way away. And that's not just anatomically, but electrically. So you can have something that's reasonably close, but it just takes a long while to get down. And these people may not have any problems whatsoever. And then suddenly you have something, like, as you said, about atrial fibrillation. I had a similar chap who was a hockey player for GB, and he was absolutely fine. He came in with atrial fibrillation conduction rate of 280 beats per minute. Obviously, that's not good. But at rest, his ECG, because he had 12-lead ECG done for the Olympics, was completely normal. And it does happen like that. And there's not a lot you can do. You know, it's just bad luck. And then dealing with the problem when it occurs.
Yeah.
So if you have a patient, for example, in the real world that has some sort of syncope, a young patient, how do you find this? Is the stress test, or how would you try to locate this kind of issue?
So if I'm expecting to look for evidence of pre-excitation, because exertional syncope is a reasonably, well, that's not true. Exertional post-syncope is a very common problem. People passing out after exercise is actually reasonably common. People passing out during exercise is much less common. So what would I do? Someone comes in, a 20-year-old, he's got an episode of syncope. I would do an exercise test, I would do an echocardiogram, I'd do a 24-hour tape, and then if I don't get the answer on any of those, and there's nothing that says I should be doing a tilt test, then I'd fit them with a ILR.
Will there be maybe a family history as well? Something maybe?
Oh yeah, we do that during you take family history during the examination. So yeah, sorry, I took that for granted.
Yeah.
Everyone in my family is dead at the age of 25. Wow, bets are off, and we've got to go and do something different.
Yeah.
Yes, Dr. Timperley, is there any way we can also look at fascicular tachycardia, how to fascicular tachycardia and supraventricular tachycardia? Is there any way to get a clear note on EKG on these issues?
Yes, I have those. I'm just looking. I'm on the wrong screen. Why don't I do one on VT in a few weeks' time?
Very good, because our fellow will
VT.
be going for exams. Yeah, that will be fine, because the fellows will be going for exam in October. So if we can get AJ can arrange another one, maybe
give me a few
after
weeks, 2 or 3 weeks time, and then I'll get one sorted.
Very good, very good.
I'm just looking.
Thank you, sir.
Perfect. Any more questions from the group? Have I frozen? Nope, maybe not. Perfect. Well, I think we're good. Dr. Timperley, I will follow up with you and we will set up another time to do a talk on that
Thank you.
before our fellows go in for their tests.
Yeah.
But I really appreciate the talk today. That was very enlightening, and I definitely am going to review it once we get it up on YouTube to scan it again. So thank you everybody for taking time out of your Sunday to speak with us, and please go enjoy your chicken, Dr. Timperley.
It's out now, so it's
Thank you so much, sir. Thank you so much. Very interesting topic.
JT,
Thank
can
you,
we
sir.
see it? Can we see it?
Can we see the
how
chicken?
good it is?
Give me 5 seconds. I'll bring the chicken in. Let me just.
Okay.
Thank you, JT. Yeah.
Julius, what do you think about the talk?
It was fantastic. Yeah, it was really good. Really, really
Very fantastic.
I wanted to ask him at the end what the prevalence of oh, that looks all right. Oh,
that looks all right. That's a bad boy. Smells amazing.
Nice one. Oh,
Yeah.
nice. Fantastic. It was a really, really good talk. Really liked it. Don't know the prevalence of pre-excitation, and is there more in Europe than in Africa, or is it the same? Is it what I mean? I wanted to ask: is it a social? I wouldn't be a socio-economic thing, but it is related to a lot of congenital cardiac. Is that right, JT?
Sorry, I just got back. Sorry, what's the question?
Yeah. You are right.
Yeah, fine. The chicken's come back. He's lovely. He's having a great life.
Julius, the issue of being more in Europe than Africa, I think a study has to be done on it. The reason why you see that it's more in Europe because there are studies in among Caucasian to show all this. When you come to the sub-Saharan Africa, you don't really have most of all these studies. Like if you come to the Sub-Saharan Africa, which is the bulk of Africa, and that is where you have the repopulations of Africa, is that you have not done enough work to say that these things are not there or they are there. You have not really done enough until you start looking for them here. That is why you start seeing them. Let me give you an example. A few years back, they would say that we don't have enough coronary artery disease. We don't have enough heart block around here, but we know that those things are there. When you go to the community, you see them there, and the chains of referral here and the chains of referral in Europe are two different things, and North America are two different things entirely. North America and Europe has similar chains of referral, but when you come to the sub-Saharan African region, you have scarcity of health professional. You have many things that count against you in order to pick up all these issues. So until we do a very clear study, you can't really say that they are not here or they are there. I think they are here, but we have not looked enough on them to pick them up. Take example, the pacemaker clinical trial. Just less than half of the year, just a single center in Nigeria has had almost 40 patients in randomization. So before, if these free pacemakers were not there, you won't see that kind of thing happening. Because if a patient comes and he cannot afford it, you go back and the patient may end up dying somewhere and nobody will talk about it. So these are the issues. So the health system, the challenges facing both are not exactly at the same level.
Yeah, brilliant. Good. That's an interesting point about screening, but what about, like rheumatic heart disease? Could that ever play a factor as well? Because you have higher incidence rate of that in population.
Yes, we have a lot.
For example.
We have a lot of congenital heart disease in the region, in the sub-Saharan Africa. But most of these congenital heart disease, they are actually being seen at the level of the pediatrics age group. So now the same thing also occur when how many pediatrics cardiology practice in the regions, and how many of them are actually seeing this group of patients. That is one. Two, those that transit into adult, how many of them are being followed by the adult cardiologist? So that is another issue. So, but you have those symptoms here. Then another issue again is that those that have complex congenital heart diseases, you know, the chances of living into adult in the sub-Saharan Africa is very rare because of the challenges they face, finances, infections, and the rest of them. So many of them end up passing on before they get into the adult age where an adult cardiologist will see them.
That's a good point, actually. Yeah, we yeah, in contrast to what happens here, I mean, in Scotland, there was a nodal guy. I think it must have been in his 60s or something. But never needed to come into hospital, and they did an echo and discovered that he had Epstein's anomaly, and he had pre-excitation as well. So Epstein's anomaly is the atrialization of the right ventricle. So the atrial valve just moves into the right ventricle, and it becomes really, really large, and the right ventricle becomes really tiny. And we usually have like pre-excitation accessory pathway somewhere. So
yeah, very correct.
Yeah, and so what
there is a work, Rogelio, there is a work we are doing currently on Epstein's anomaly.
Okay.
And we have not published the data, but very soon I'm sure we'll publish those data. But it will shock you that when you look at those data, most of the patients we are picking up that are included, they were people that are of young age group. And most of the women that are there, they actually came into the picture because they got married. And you know, in Africa, when you get married, as a woman, the household, the work become very tedious for you because everybody will come for your wedding. In fact, the preparation of that wedding, you'll be so much involved in it. And you know, you have the traditional wedding, you also have the white wedding, which is a church wedding. If you are a Christian, the Muslim, you do the Islamic rite. Then once you finish, everybody will go to their house and you'll be left alone with your husband. So in your mother's house, you may not be sweeping the house, you may not be cooking and taking stress of cooking and doing all that because there are other siblings. But when you now get into your own house, where now you are now the woman of the house, you do all the cooking and all the rest because of the tradition of the people. So at the end of the day, the young lady is being stressed off and it manifests with her failure. So that is the point. Most of these people now end up coming to the cardiologist. And when they come, they feel that,
oh, we've lost him.
That's an interesting manifestation of
large.
Oh, he's back.
So these are the things that we talked about. So AJ, you cannot rule out culture. Leave cultures the way they are. Over time, they may be modified, but leave them to evolve with the people. That is the way I see it, sir. So when we publish that paper, we'll show it to you because these are the things that we're pointing out in that paper. So most of the patients, although we have some we picked up at above 40, but most of them is below 30. And the women that were there, most of them are below 30, and they came in because they got married and they went into, within 2-3 months of marriage, they enter into this problem and they pick them up. And funny thing, they don't do well. They don't do well here because maybe when the paper comes out, we'll talk about more on it.
I would love to read it. So my mother-in-law is a pediatrician out here in Rwanda, and works in early childhood development, works a lot with new mothers, and also like people just starting out with families. So it'd be very interesting to see, that manifestation as a result to, environmental stress that you just don't even think about.
Yeah. So there are many things that really stresses the environment, like in Europe, you don't have that so much. I know your culture has evolved far more than what we have here. And you can pick people up at much age group, but here most of them are being picked up at the point where they are now being left to fend for themselves. They now involve themselves in strenuous activity. They will end up coming down with problem, and when you do the echo, you pick them up. Atrialization of the right ventricle.
Interesting. This is a really good talk. Thank you, Dr. Date, for the
Thank you very much.
This is fantastic.
Yes, sir.
Well, we look forward to your upcoming paper, and to everyone studying for your exams. If you have any questions for us regarding device or electrophysiology, just reach out to the group. We're here to help in whatever capacity we can. But thank you everybody for taking time on your Sunday. I know we took up almost 2.5 hours of your time, so I really appreciate y'all sticking with us for this.
Thank you, sir.
Thank you so much.
Thanks, AJ.
Thank you.
Yes, sir. Thank you so much. Have a great day.
Thank you, Dr. Timperley. Thank you, Dafe. Thank you.
Thank you,
Yes,
sir.
sir. Thank you, Julius. Thank you, everybody. Thank you so much. I appreciate you.
Thank you. Nice to meet you again.